All right, today we will be covering the urinary system, chapter 11. So here are some learning objectives. We are going to be covering a very short chapter today. We're actually going to not cover how urine is formed and the kidney and nephrons and all of that fun stuff. So it's going to be a very short chapter today. So we're just going to cover really the disorders of the urinary system. And a lot of these urinary system disorders are caused by illnesses such as, diabetes, hypertension, some inherited conditions because of progressive renal disease or renal failure. So the first thing is urethritis is just an infection of the urethra. Now, just to go back to some anatomy of the whole urinary system, we have the kidneys. The kidneys kind of look like this. We have two kidneys. And then we have these things coming off the kidneys called the ureters that attach to the bladder. And then the bladder has a urethra, and then we pee out of the urethra to the outside world. So urethritis is an infection of the urethra. So the urethra would be there. Cystitis would be an infection of the urinary bladder itself. So that's where the urinary bladder is. Pyelonephritis is an infection of the kidney itself. So your kidneys are up there. Kidney stones, I'm sure you've all heard of. Typically, those are caused by urinary tract infections. It could be related to an enlarged prostate gland if you're a male. pH imbalances of your bloodstream. It could be because you drank too much caffeine or you've ingested too much calcium. Basically, kidney stones are just hard stone-like substances that are made of calcium, phosphate, uric acid, and protein. And they form in the renal pelvis, which is part of the kidney. And typically, they're going to pass unannounced in the urine flow. You're not going to know that you have a kidney stone. They're going to be so really, really tiny that you don't even know that they're there. However, you can feel that you have a kidney stone. You might have some back pain that lets you know that the kidney stone is there. But if the stone is large, it can actually block the urine from going from the kidney to the bladder. It can actually block the ureter, or the kidney stone can actually reach the bladder and get dislodged in the bladder, or it could block the urethra. So your kidney stone could actually be lodged in a couple different areas. So the ureters, I already said, connects the kidney to the bladder. But what happens is wherever it blocks, if the kidney stone actually blocks a portion, you'll see a backflow of the urine because the urine can't flow forward and you typically can't pee out. And that backflow will, one, become very painful, and two, it will build up an infection inside your body. All right, one of the first signs of nephron damage. So nephrons are basically a small part of the kidney, a large part of the kidney. But if we look at the kidney at a microscopic view, if we look at it under a microscope slide, we'll see a bunch of these nephron things. And basically, nephrons are how urine gets formed in the kidney. So nephrons are basically microscopic views of the kidney. So one of the first signs of kidney damage or nephron damage is albumin, white blood cells, or red blood cells in the urine. So you know that there's going to be some kidney damage if you see albumin, white blood cells, or red blood cells in the urine. So typically we don't want to see proteins in the urine. Albumin's a protein. We don't want to see white blood cells in the urine, and we don't want to see blood in the urine. We don't want to see red blood cells in the urine. Females will see red blood cells in the urine during menstruation, but that comes from a different outlet than the urethra. And you can go to the doctor's office and you can pee in a cup and do a urinalysis that can detect whether or not you have protein in the urine, such as albumin, white blood cells, or red blood cells in the urine. And uremia is just basically an accumulation of urea and other waste products in the blood. So when we form urine, when we break down proteins and stuff like that, we form urea. So accumulation of urea and other waste products in the blood means that the kidneys aren't doing their job. And that occurs when the kidney damage is so extensive that more than 2/3 of the kidney, or more than 2/3 of the nephrons, are inoperative. So your kidneys can actually take a pretty good hit before you start to see signs and symptoms of damage. So although those waste products, or those nitrogenous waste products, can cause serious damage, it's actually the retention of water and salts after damage that is of greater concern, because what happens is that it leads to edema, or fluid accumulation in the body tissue. So if you look at someone with edema, they have what's called pitting edema, where you can actually press on the skin and it'll leave an indentation on the skin. Or if you eat a bunch of Chinese food the night before, last night, you're going to wake up today and all of your fingers are going to be swollen. So that's because you ate so much salt. We're going to retain water because we ate so much salt. So, it's not going to be that you're in kidney damage because you ate Chinese food. That's not what I'm saying. But over time, or with kidney damage, the retention of salt and the retention of water is going to lead to this thing called edema, which is the accumulation of fluid in the body tissues. And because we are now retaining salt, which is an ion, and we retain other ions as well, that ion imbalance, or that abnormal ion balance, can actually be so disruptive that we could lose consciousness and possibly go into heart failure. One, because of the edema, and now that we have so much fluid, the cardiovascular system has to work extra hard to try and compensate for that extra fluid. And also because we have so many, we have a buildup of those ions, we could actually do damage. Some of those ions are very detrimental to the heart in increased quantity. So, like for example, if you have a high potassium level, high potassium levels can be very put your heart into life-threatening situations, life-threatening rhythms. All right, so basically you can just hopefully get the kidneys working. If you need some antibiotics, hopefully antibiotics will, cure whatever urethritis or cystitis or pyelonephritis is going on. Antibiotics are good working on the kidney level. Hopefully all of these things can be taken care of. Now with kidney stones, that's going to be a different treatment. Sometimes the kidney stone can pass on its own. Sometimes the kidney stone will need some sort of extra help to get out of, to become unblocked. You might have to have surgery to remove the kidney stone, where they would go in and they would kind of pull out the stone and place a stent to open up that area so that the kidney stone can pass. There's a procedure out there called extracorporeal shockwave lithotripsy. It's abbreviated ESWL. You don't need to know this, where you kind of like sit in a bathtub and they put shock waves through the bathtub to where it kind of breaks up the kidney stone in your back. So now, if let's say your kidneys are so damaged that they can't function anymore, they can't filter, they can't clean your blood like they're supposed to, because remember, kidneys clean blood and kidneys produce urine. So let's say your kidneys can't clean the blood anymore and kidneys can't produce urine anymore. We have different mechanisms for helping out a patient who can't do this. We call this hemodialysis, or dialysis would be the general term for it. We can use an artificial kidney machine, and that would be hemodialysis, or we could use this thing called continuous ambulatory peritoneal dialysis. It's called CAPD. So the broad definition of dialysis is basically the diffusion of diffused molecules through a semi-permeable membrane that has a pore size that allows for only small molecules to pass through. Okay, so basically in dialysis, what we're doing is we're going to clean the patient's blood for them. We're going to extract the waste products out of the bloodstream for the patient. Now, we can do this one of two ways. We can do this through the artificial kidney machine, or we could do this through peritoneal dialysis. If we use this artificial kidney machine, what we would do is we'll take the patient, we'll hook the patient up to the machine, and we'll take the patient's blood out of the, kind of like an IV. The patient's blood will be taken out of the body, and it'll be cleaned, and then it'll be put back in the body. And it's through this solution called dialysate. And basically, this dialysate is going to be what's used to create this gradient to allow the chemicals or the waste products to go from the bloodstream into the kidney machine. We're not going to go into the chemistry behind it. But basically, this dialysate and the kidney machine, this artificial kidney machine, is going to extract those substances from the blood, the waste products, the waste products, the toxic chemicals, the drugs, whatever, from the patient's bloodstream. And what goes back into the patient is clean blood. Excuse me. And typically, once you start hemodialysis, you're going to be on hemodialysis for 3 to 6 hours per week. And it says twice a week. Now, I used to manage a dialysis clinic up in Raleigh, and I would say no one was twice a week. Everyone was 3 times a week. But the book says twice a week, so we'll go with twice a week. You either go on Monday, Wednesday, Friday, or you go Tuesday, Thursday, Saturday. This 3 to 6 hours, that's pretty accurate. We also had a program for, working adults where they would come in on Monday, Wednesday, Friday nights, and they could have dialysis during the night so that they could still go to work the next day. And they would come in for, 3, 4, 5, 6 hours, and we could run them at a slower time so that they could have more of like a 6 or 7 hour dialysis process to get their sleep in. Now, with this CAPD, or this continuous ambulatory peritoneal dialysis, we're not actually dealing with the blood. What we're doing is we're putting this dialysate into the abdominal cavity. So you're going to have these patients are going to have this catheter that's placed into the abdominal cavity. And then you're going to have this bag of fluid that has this dialysate, and you're going to put this dialysate into your abdomen, and this dialysate is going to sit there for about 4 to 8 hours. And we say that's called your dwell time. And once the dialysate has sat there or dwelled for 4 to 8 hours, during that time, it's collecting all of these waste products from the bloodstream. And then all you're going to do is dump out the waste products into the toilet and go about your day. So with the hemodialysis, you're actually hooked up to a machine for 3 to 6 hours, and you're sitting in a chair, you're laying in bed, you really can't get up and move. With the benefit of peritoneal dialysis is that once you put this dialysate into your abdomen, you can go about your day, you can go to work, you can go shopping, you can do whatever. And then if you're at Walmart or wherever, once you get back home, you can empty out the dialysate into, like I said, the toilet. So your activities of daily living, your normal activities, aren't going to be disrupted by peritoneal dialysis. And the good thing about all of these is that, let's say you need to go on vacation or you want to go on vacation. Typically, there's going to be a dialysis facility, hemodialysis facility within 30 miles of your vacation spot. So we can always accommodate patients that are traveling. Or, let's say you're going overseas and you're a peritoneal dialysis patient. We can ship all of your medication supplies to your hotel room so that you don't have to bring them on the plane or check your bags or something like that. So we can ship all of these supplies to your destination so that this doesn't have to be interrupted. So with hemodialysis or with peritoneal dialysis, it doesn't have to be, a life-altering process. And then usually with hemodialysis and peritoneal dialysis, your kidneys don't work, so you're going to be placed on the kidney transplant list. And because you are in renal failure, we have to do the work of the kidney, whether it be peritoneal dialysis or hemodialysis. And with kidney transplant, obviously there's going to be a possibility of organ rejection, but typically the 1-year survival rate is going to be 97% if you receive a kidney from a relative, and about 90% if you receive a kidney from a non-relative. Now we are looking at, not we, because I'm not, but researchers are looking at, creating kidneys that are being created in the laboratory, and we have used a pig kidney. I don't know if you saw that in the news within the past year and a half or so. That patient has passed away from using a pig kidney. So, and you can see here that we actually only need 1 kidney in order to survive. So when they do the kidney transplant, they actually don't take out the old kidneys. They're going to leave them there, but they're going to just transplant the new kidney into the patient, and they're going to leave the diseased kidneys or the failed kidneys in your body as well. And they're just going to put the new kidney in there. So that's it from the urinary system. So that's all we're going to cover for this chapter. So if you have any questions, please let me know. Take care.